So I'm going to talk about um, multiple rod constructs in deformity surgery, and I'm going to lean on my strength as an orthopedic surgeon and delve into some of the biomechanics and biomaterial science for rods. Is this showing up here? Okay, good. Okay, so first we're going to review some of the basic material properties. Then we'll talk about some indications for multiple rod constructs. I'll show you some types and examples of multiple rod constructs, and then we'll address the question, is more necessarily better? So this is the stress strain diagram, which you've all seen before. I just want to review and highlight a few important concepts. So the elastic modulus is the stiffness of the material and its resistance to deformation. It represents the slope of the stress strain curve. When in the elastic zone, material will return to its original shape when the deforming force is removed. So think of this: when you hold the rod in your hand, you try to bend it, and you can't bend it, or you bend it a little bit, it springs back to its original shape. That you're dealing with the elastic modulus at that point. The yield strength is the force greater than the yield point of a material, and it represents the limit of the elastic zone. And once you apply a strength beyond the elastic limit, you're into the plastic deformation. So think a bit about this as the force you apply to a rod bender to contour the rod. And then finally, the fatigue strength is the resistance to breakage over many cycles. So now you're holding the rod, you're wiggling it back and forth, and maybe for 1,000,000 cycles before it breaks, or maybe it doesn't break at all. And then contrast that with using a French bender and bending it back and forth. Maybe you break it after a few hundred cycles or a few thousand cycles. So the number of cycles until failure also depends on the amplitude of the force application. And so the elastic modulus, we all know this. So the cobalt chrome has the highest elastic modulus, followed by stainless steel, then Ti. Also, cobalt chrome also has the highest yield strength, and also has the highest fatigue strength. So at 400 newtons, cobalt chrome lasts 300. This study showed that cobalt chrome lasts for 350,000 more cycles than Ti. So why does rod choice matter? Just to set the stage, this is a clinical case here. Previous patient with a 4-5 fusion, proximal degeneration and kyphosis, coronal and sagittal imbalance. So we took this patient to surgery, did an L4 PSO, and then instrumented from T4 to pelvis. She did great, but then 6 months later, you can probably predict that one of the rods breaks, right? And this is a very typical pattern where the rod breaks at the level of the osteotomy. So we take the patient back and add more rods. The ISSG studied this at the risk factors for rod failure and found that the incidence of rod fracture after deformity was about 9%. So non-significant factors were the number of levels, the rod diameter, the proportion of 6.0 millimeter rods, and the grafting material. But the significant risk factors were whether you performed the PSO, the rod material, and the amount of correction. And then in their multivariate analysis, they found that the PSO was the most important factor. So those patients who had PSO had a rod fracture rate of about 22% compared to 4.7% without a PSO. And then over time, this gets even worse. So with 5-year follow-up, 40% of patients eventually had a rod fracture. So rod fracture really just represents fatigue fracture. So either the biomechanical environment is too demanding, or there's pseudoarthrosis, but there's micromotion at the level of that rod, and it continues to wiggle in its cycles and then eventually breaks. So the mode of failure is fatigue failure. And most common sites of pseudoarthrosis are at the 3-column osteotomy, multiple posterior column osteotomy, or across the lumbosacral junction. Greater lumbar lordosis or thoracic kyphosis correction also is a risk factor for pseudoarthrosis and rod fracture. And this makes sense because the greater the deformity correction, the more demanding the biomechanical environment. And this figure shows a relationship between the angle of the rod bend with fatigue strength. So this group looked at different degrees of bend for the rod, 20 degrees, 40 degrees, and 60 degrees. And then they cycled the rod and found that with increasing bend, it decreases the number of cycles until failure. So how do we deal with rod fractures? More rods. All right, so we add more rods. So with a quad construct like this, this group showed that there are less lumbosacral rod fractures with multi-rod constructs. And this is a really good paper. So if I would add this to your reading list. It's a paper from the ISSG published in the Seminars of Spine Surgery, and it really goes through a lot of information about the use of supplemental rods. And I'm just going to go through some of the definitions just to talk about standardize some of the terms that we use when we talk about supplemental rods. So satellite rods are defined as where we put the instrumentation in the levels adjacent to the osteotomy, and then the rod that connects those is actually independent of the primary rod. Accessory or outrigger rods are those rods which can span the osteotomy site but are connected directly to the primary rod. Delta rods is a rod that's connected at the proximal and the distal end, but not contoured in the middle, but they serve mostly to buttress the construct across the, and provide some more stability. And then there's the kickstand rod or the iliac accessory rod. And then this is basically a rod that's connected to the primary rod proximally, and then distally it's connected to a separate pelvic screw. So it's useful in terms of getting additional coronal correction, or also as a supplementary rod across the lumbopelvic junction. This group showed that the distal connection also matters. So if you put the connector, they looked at different groups of patients where the connector was proximal to the S1 screw, between the S1 screw and the pelvic screw, or distal to the pelvic screw. And what they found was in the first group, 5 out of the 6 patients actually had a rod fracture. 4 out of the 17 patients in this group had a rod fracture, and 1 out of 16 in this group had a rod fracture. So that would suggest that connecting distal to the iliac screw, connecting your accessory rod distal to the iliac screw is protective against rod fracture. So is more necessarily better? Should we just be using 6.35 cobalt chrome quad rods in all of our constructs? Would that solve all our problems? Well, just to bring back to some of the other orthopedic literature, we know that more is not necessarily better. So this is a tibial plateau fixation. This is what's called a dead bone sandwich. There's just too much fixation here, too much metal. It's too stiff, and it's definitely not the optimal environment, not an optimal biomechanical, biological, or mechanical environment for healing to occur. So the fracture fixation principle is load sharing, and we want to distribute the forces across and along the bone to prevent stress risers and stress shielding. So notice here the use of the long plates to distribute the force along the diaphysis and spread out the forces. Now, with regards to stress shielding, so Wolff's law states that bones will adapt to the forces that they see. So with over time, they will strengthen and remodel to resist load forces. But conversely, if the fixation is too stiff and the bones don't see any stress, the bones will resorb. So this phenomenon can lead to non-union and implant failure. Another concept is the stress risers. So in the distal humerus, the principle is to use different length plates so that the plates end at different heights, and you're avoiding concentration of forces at the end of the construct. So by doing a construct like this, are we heading towards something like this? Are we making the same mistakes? Are we just trading one problem for another? So we try to fix rod fracture and osteoarthrosis. We fix it with multiple rods. We make a stiffer spine. We have a less rod fracture rate. But does this lead to a concentration of mechanical stress above the fusion construct? Does too stiff a spine lead to increased PJK and PJF because of stress risers? Does too stiff a spine lead to stress shielding and non-union? So this is a case that was in the Seminars for Spine Surgery paper. And so they show this example of a case of 6 rods across the PSO. And that PSO actually went on to non-union and bony resorption. So there's stress shielding and non-union across that osteotomy site. Now, we know from cadaveric studies of intradiscal pressure that the more levels you fuse, the stiffer the fusion construct and the greater the intradiscal pressure of the adjacent disc. From the vertebroplasty literature, we know that cement augmentation leads to increases in stresses and strains of the levels above and below the augmented vertebra and may increase the rate of fracture of adjacent vertebra. This Korean group looked at rod stiffness as a risk factor for PJK. They compared cobalt chrome multiple rod constructs with titanium 2 rod constructs. This is a survival curve for PJK. Cobalt chrome is the solid line and titanium is the dashed line. And you can see that cobalt chrome is definitely a risk factor for a PJK compared to Ti. And this is their data. So 60% of patients in the cobalt chrome group ended up with PJK compared to 26.5% in the Ti group. But if you look at the rod fracture rate, Ti group had a much higher rod fracture compared to none in the cobalt chrome. So it does definitely look like we are trading one problem for another. So if you think about the biomechanics of the native spine, this figure shows the compressive strength of each of the vertebral bodies at different levels. So you can see that the lumbar spine is much stronger. There's much more resistance to compressive strength compared to the upper thoracic spine, which even has maybe about a third of the compressive strength of the lumbar spine. So we know that vertebral body strength changes by level. And then this is a dot plot of the vertebral body strength over age. And it shouldn't come to a surprise as anybody that vertebral body strength also changes by age. Another ISHD paper that looked at the density of pedicle screw constructs and whether that had an impact on PJK. So they looked at the overall screw density and found that if there was greater than 1.8 screws per level, there was a 17% rate of PJF. And if there was less than 1.8 screws per level, there was 9.4% risk of PJF. The rod material and the rod diameter were not significantly associated with PJF. And the degree of lumbar correction was no different between the two groups. So this is the idea behind the soft landing, where you want to transition from a more rigid spine from a more rigid construct as you go up into the thoracic spine to a less rigid construct, make a gradual change, and that soft landing technique might be possible as a prevention strategy for PJF. You can see this group here demonstrated using the use of hooks as a way for soft landing. Now, other ways to adjust rigidity, I want to take this back to, again, ortho and think about X-fix principles, right? So if we look at the X-fix and fixation of long bone, this can easily be, I think, translated to the concepts of the spine and an osteotomy site. So we just think of the fracture site as the PSO. What are the ways that we can increase or adjust the stability of the construct? So controlling both near and far ends of the bone segment. So making sure that you have that you don't leave a big gap in your fixation across the PSO. Decreasing the distance between the rod and the bone. So hubbing your screws. Increasing the number of connecting rods. So this is your multi-rod construct. Increasing the diameter of the pins. So big screws and big rods. And using multiplanar fixation. So this can be applied, for example, if you use different separate pelvic screws, or there's also the technique where you alternate your pedicle screws from medial to lateral, and you can alternate the rod from those different screw trajectories. So what exactly are we trying to achieve? You want to match your surgery to what the patient needs. If you're performing less deformity correction, maybe your construct needs to be less stiff. Think about using multiple rods across PSO sites or across the lumbosacral junction. Use a stiffer construct where you need fusion and less stiff as you transition to native spine. If you have weaker bone, use less stiff rods because you don't want to overpower the spine. So we want to move away from a sharp transition like this from a rigid to a non-rigid construct and avoiding the stress riser and try to think of creating something more like this. And going back to thinking about the native spine again, We want to think about a soft landing, not creating something too stiff at the top, and then at the bottom using multiple rods for better fusion, but also considering the fact that if we make it we want to avoid stress shielding by not making construct too stiff. So what would be my dream rod? If I could have a machine, I think that the answer is not let's use the strongest, stiffest rod out there. I think it's a bit more nuanced than that. If I had a machine where I could dial these different parameters and make a rod specific, customized to the patient's case, the patient's characteristics, that would be my ideal dream. So if I could adjust the stiffness, adjust the rigidity to have it stable enough for fusion, and hold deformity correction, perhaps as close as you can to match native bone. I think that would be ideal. For the yield strength, I would want this to be greater than any one-time large mechanical load for the patient. That might depend on the patient, if they're not, depending on their functional status. So I might want it to be able to resist ground level fall, or perhaps a car accident, or perhaps even roller coaster or skydiving or something. That would depend on what the patient's doing. And then the fatigue strength, I would want a rod that has an unlimited number of cycles at a normal physiological load. So patients getting in, it would be able to resist the day-to-day cycles of that rod for the patient, for example, getting out of a chair or a bed, walking, jogging, bending. So this is the art of medicine. So it's got to be not too hard, not too soft, but just right. Thank you.
Well, thanks a lot, Cliff, for a great review of the biomechanics. So obviously there's the fusion part. And so what are your strategies for fusion? And because rods and fusion are obviously a different component. And then the other thing, let's say you did a T10 to pelvis on a average male in terms of size and age and everything. What would be your ideal construct in terms of distal fixation, rod use, and things like that? And do you believe in using cobalt on one side, titanium on the other side, maybe to get the benefits of everything?
So in terms of fusion, I've kind of, this is kind of learned for you. I really focus on decorticating the facet joints, and I actually put like a little shim of bone in between the facet joints, because we're sort of like, instead of trying to bridge across the TPs, which may be a critical gap that it's too much for the biology for bone healing. You only have to cross a few millimeters when you fuse across the facet joints, and then using for a T10 to pelvis. I have actually tried using cobalt-chrome on one side and tie on one side, and so far it seems to work. And I will bridge across the lumbosacral junction with a third rod. I haven't gone to using 4. Again, it kind of depends on how much correction I'm doing. If if I'm doing a PSO, I may add a 4th rod. But if it's really just multiple PCOs correcting sort of like a medium deformity, then I might just add a 3rd rod, and I would cross that. And I have used that dual head screw at S1 to sort of use that. But that other study that I showed that shows that you have to go past the ILEX screw. I haven't done that, but maybe I might start doing that.
Okay, and then any other questions? Bob?
I'm not sure. Is this working? Yeah, I guess it is. So great talk. I think you hit on a lot of the primary issues, and I totally agree. There's this conflict between stiffness. We need a stiffer rod for healing, but the trade-off of junctional problems as a result. I wanted to call out, you didn't mention kind of a startup company, and I do have a conflict. I've worked with them on some of their design projects. The company is called Mirus, and the material that they're using is called molybdenum. It's molybdenum rhenium, and rhenium is the heaviest element on the periodic table that's not radioactive. So it's kind of funny, the acronym for their metal alloy is MORE, M-O-R-E, so it fits with your topic. But they've recently come out with a product that I hope gains some traction, which is a 5.5 diameter rod, but then staggered diameters. So as you reach the top of the construct, you can put in a rod that is a smaller diameter and therefore less stiff at the junctional aspect. And of course, we've done that at cervical thoracic junction for years, but we've never thought of it, I think, as a possible approach in sort of thoracolumbar constructs. So I just want to call out I think it's a design that takes into account a lot of the features you're showing, and there's not yet clinical data, but I think it's worth a try. And the last thing I'd say is there's yet a further trade-off, which may be in terms of sort of infection susceptibility, and cobalt chrome was one and stainless would be the other, that I've had late infections become clinically significant, whereas I never saw that around titanium, I don't think.
Yeah, I'd be interested to hear more about the Moore rod, and learn more about the characteristics of that and how it's used. Yeah, yeah.
Okay.
There are companies, that was an excellent talk, thank you. There are companies that try to sell us pre-contoured rods with alleged less notch sensitivity to meet our alignment goals. So my favorite new elusive goals. What do you think of those, and what do you think about all this focus on trying to make us more dependent upon technology rather than good surgical craftsmanship? Is that a worthwhile thing? I hear these reports of people who have these pre-contoured, no prog names given here, rods, and they have about 3 or 4 of them on the field, throw them away, and then bring out the good old French benders. So
Yeah,
what do you think about that?
Well, I mean, I guess that's the whole argument of is it going to what sort of technologies can we use to make it easier for the surgeon, right, and make things faster in the OR, and that's kind of the trade-off. If you're looking for more craftsmanship and artsmanship, that's going to take longer in the OR, and maybe that's kind of like the lost art of medicine. I'm kind of like the dinosaur now at my place. I still make strut grafts out of fibula for my corpectomies, and yeah. Anyway, so.
Okay, thanks. I think we got to move on to the